Good morning, everyone. I am Dr. Lavanya David Martin, Assistant Professor, Sri Bharati Arts and Science College for Women, Pudukkottai. Today we discuss about pulmonary tuberculosis. Tuberculosis is the infectious disease primarily affecting lung parenchyma. Is most often caused by Mycobacterium tuberculosis. It may spread to any part of the body, including meninges, kidney, bones, and lymph nodes. It's the one of the most prevalent infection of human beings and contributes considerably to illness and death around the world. It is spread by inhaling tiny droplets of saliva from the cough or sneezing of the infected person. It is slowly spreading chronic granulomatous bacterial infection characterized by gradual weight loss. This is the Mycobacterium, scanning bacteria, microscopic microorganism tuberculosis. Types: pulmonary tuberculosis, avian tuberculosis, Mycobacterium avium of birds, bovine tuberculosis, Mycobacterium bovis of cattle, Miller tuberculosis, disseminated tuberculosis. Incidence: with the increased incidence of AIDS, TB has become more problem in the USA and the world. It is currently estimated that half of the world's population is infected with Mycobacterium tuberculosis. Global emergency tuberculosis kills 50,000 people a day. 2.3 million die each year. Etiology: Mycobacterium tuberculosis droplet nuclei, that is coughing, sneezing, laughing, exposure to TB. This is the affected area of the pulmonary tuberculosis. Here are some risk factors, that is age. Infant and adolescents are at high risk of disease. Close contact with an untreated sputum positive patient. Impaired host defenses, immunodeficiency state, particularly that associated with HIV infection. Immunosuppressor related to accompanying viral infections or drug induced malnutrition. Other diseases states Hodgkin's lymphomas, diabetes mellitus, leukemia, malignancy, severe kind of kidney disease, silicosis, prolonged treatment with corticosteroids. Person who tuberculin skin test results converted to plus in the past 1 to 2 years. Person who have CXR suggestive of old TB, immunocompromised status, drug abuse and alcoholism, people lacking adequate health care, immigrants from countries with higher incidence of TB, institutionalism, long-term care facilities. Now we move on to pathophysiology. Initial infection or primary infection. Entry of microorganism through droplet nuclei. Bacteria is transmitted to alveoli through airways. Deposition of multiplication of bacteria. Bacilli are also transmitted to other part of the body through bloodstream and lymph node, causes ill inflammation. Here I have attached some pictures. Phagocytosis by neutrophils and macrophages. Accumulation of exudate in alveoli, bronchopneumonia. New tissue masses of live and dead bacilli are surrounded by macrophages which form a protective mass around granulomas. Granulomas then transforms to fibrous tissue mass and the central portion of which is called John tuberculi. The material, bacteria and macrophages, becomes necrotic, forming chest mass becomes calcified and becomes collagenous scare. Bacteria become dominant and no further progression of active diseases, inadequate immune response, activation of dormant bacteria. This is also the pathophysiology. Here releasing chest material in intro branch, bacterial became airborne resulting in further spread of infection. Ulcered tuberculin heals and becomes scar tissue. Infected lung become inflamed. Further development of pneumonia and tuberculosis formation. Unless the process arrested, it spread downwards to the human of lungs and later extend to adjacent lobes. Next, coming for clinical manifestation, constitution symptoms, anorexia, low grade fever, night sweat, fatigue, weight loss, pulmonary symptom, uh, dyspsia, non-resolving bronchopneumonia, chest tightness, non-productive cough, micropurulent sputum with hematopoiesis, chest pain and inflammation. Here are some complications that are from bones, brain, liver or kidney, heart, pleural effusion, TB, pneumonia, serious reaction to drug therapy, medical management. Here pulmonary TB is treated primarily with a anti-tuberculosis agent for 6 to 12 months. Pharmacological management. Here first line of antibacterial medications I have given here. Streptomycin, isoniazid, rifamycin, pyridoxamide, ethambutol. Now I am going to prevention measures I am telling you. Isolation, proper ventilation of the room, cover the mouth, wear mask, finish entire course of medication and vaccination. Here I conclude a person may contact pulmonary tuberculosis from inhaling droplets from a cough or sneeze by an infected person, granuloma in lung tissue. Thank you.